a project that I've been working on with a number of partners here in Oregon, where we are attempting to explore the idea of school-based healthcare-specific alternative payment models. So a little disclaimer, a lot of the presentation is about the process we have gone through because we don't have the end solution quite yet, although I feel we're getting closer every day. So this is an ongoing project. So I'll just share what we have so far. So I'm gonna give you a little bit of background. Need to sort of set the stage by talking about the landscape of healthcare reform in Oregon, and then I will talk about our Alternative Payment Innovation Project, so we call this APIP. The defining of SBHC value as part of that, and then the potential APMs that we've explored and what we're focusing on now. So in Oregon, we have coordinated care organizations. In other parts of the country, they're called care organizations. They're pretty much the same thing. And in Oregon, they started around 2012 with some legislation. And their goals are to meet the triple aim of better health, better care at lower cost. And there are they have 6 ways that they try to accomplish this. So by paying for outcomes and health and trying to move away from fee-for-service, that's a very strong push in the state. So they want to pay for people to be healthy, not for sick care necessarily. There's supposed to be a sustainable rate of growth. So they have a global budget with a fixed rate of growth, which in theory allows them to pay for things differently so they can maximize their payments. They have to measure their performance, so they have consistent and aligned performance metrics that are measured, and those are tied to incentive payments that come from our state Medicaid. Whoops, I did not mean to do that quite yet. Let's see here. So they have, the idea is that they have a shared responsibility with local and regional focus. So we have, I believe, 17 CCOs in the state right now. They all have community advisory councils and a number of partnerships that are set up differently around the region. They are required to have transparency in their price and quality, and they need to use best practices to manage and coordinate care, which includes a strong emphasis on integration of physical, behavioral, and dental health services that result in cost savings and will improve outcomes. So what it actually is a network of all of the different types of healthcare providers. They have the one global budget, and like I said, they're governed in partnership. So in our project, we worked with mainly with one coordinated care organization, which is in the Portland metropolitan area, and it's called HealthShare, and they have about, I think, 250,000 plus members now, which is about a quarter of our state's Medicaid population. So they're big, and they include 4 primary care plans, 3 mental health plans, and 9 dental plans. So because they're supposed to be regional, each CCO looks different, and all of the other CCOs in the state don't look like HealthShare. But since they're the ones we worked with, then they're the ones that I'm giving as an example. So why alternative payment models? the idea is that in order to change the way that healthcare is provided, we need to pay for it differently. So they allow for innovation at the local level. It increases the ability to provide traditionally non-billable services, which of course is the SBHC world. And they reduce the incentive to focus on the billable visits. So they allow for service delivery changes that result in more patient-centered care and a broader range of services. They allow for things like addressing the social determinants of health, and they've been there's been a very huge emphasis on alternative payment models in Oregon. The issue is that all of the APMs have been focused on the medical home or primary care home providers. And as you all know, school-based health centers are not always the medical home for many of the patients that we see. So this is an issue for us in terms of sustainability and reimbursement. So let's see. Some of the, there are a number of different APMs, but these are some of the key ones, each of which kind of are umbrellas over different variations of these kinds of APMs. So there's the primary care capitation, which is, you know, a fixed amount of money per patient for a specific unit of time that's paid, usually in advance, to the provider for healthcare services. So a per member per month payment is primary care capitation. There's pay for performance incentive types of alternative payment systems. So those are systems that offer some kind of financial reward to providers who achieve or exceed performance on specific quality and cost measures or other kinds of metrics. The fee for specialized services mean that it's the method of payment that is essentially a fee for service, but they may provide enhanced payments for certain types of services, or they may provide supplemental payments, additional payments that are based on specific services. And then we talk about braided funding kind of as an APM as well, because use of multiple sources of funding is always another way to, you know, sustain the services that we provide. That's something we all already do, but it's just worth mentioning. So let's see here. So what led us to do this work is that we had some legislation that we were able to pass, our alliance was able to pass in 2013, which established SBHCs in statute and then appropriated funds for SBHC expansion and to incentivize participation in healthcare reform. And that last bit led to the state of Oregon being able to put out what they call innovation grants for school-based health centers, and this project was one of the grants. We also, that same year, passed a bill that encouraged CCOs to partner with SBHCs. The language actually says required to the extent practicable. So it strongly encourages CCOs to partner with SBHCs and other school health providers as they're developing basically their local plans. And it has actually helped. It's made an impact. It's allowed school-based health centers to sort of have a voice with their CCO. So just a little bit of policy, because I'm a policy person, for anyone that's interested. So the project itself, the idea behind the project was, of course, overall, we want to improve the effectiveness of delivery through school-based health centers for children who qualify for medical assistance, and that's because this, the particular focus of the work and the grant was to work with CCOs who are, of course, paying for Medicaid patients and not all patients. And then to improve the coordination of care to patient services by CCOs and SBHCs, which is something that the CCOs are supposed to be doing. They're supposed to be ensuring coordination of care for patients, integration of care, again, between the different types of service providers. So these were the participants of our work group. We've had 3 different counties in the Portland metro area participate, and then the Oregon School-Based Health Alliance, who's currently, we're leading the process, although last year Multnomah County and our alliance group was partnering on it. And then the Oregon Health Authority has been involved and is our funder. And then Care Oregon is part of HealthShare, the CCO. It's one of the medical payers. And Family Care is actually a different CCO that's been sort of involved on the fringes. And then the Oregon Primary Care Association has also been involved because they've been pushing their own alternative payment methodology initiative within federally qualified health centers. So it was really important to have them at the table. And the group met monthly for the first year, and now we meet quarterly. So in the first year, we started off with these key questions. And the first question, well, the questions being, what is the problem trying to be fixed? And then what is the value of school-based health centers to payers? And then how would an APM fix the problem? And then the final question is, who's responsible to pay for which pieces of care within the school-based health center that are happening? So when we talk about what is the problem that is trying to be fixed, we've talked about how school-based health centers are positioned to serve the needs of adolescents and children and youth, but they lack the funding to do all of the services that would be ideal, or sometimes are providing services without being reimbursed for them because they're not currently billable. So, for example, I'm sure you all know all of these, a lot of the Hallways to Health work, but other things too, like coordination between the school-based health center provider and the primary care provider, and other types of outreach, school activities, school engagement activities, and all of those things. So we felt that developing an APM that's specific to school-based health centers would provide us with the, hopefully more flexible funding to be able to support these services. One of our challenges that we came up with as we sort of muddled our way through in the beginning was not having data around the non-billable services. So that makes it really difficult to say which services should be paid for and why we should be paying for them. And another challenge that we came across with when we were talking with the CCOs is we realized that we weren't clear. We realized after they asked that we weren't clear whether we're asking for the same amount of money distributed in a different way, or if we're actually asking for more money to be reimbursed for the additional services. And what the CCO's perspective is that they don't actually have more money. They have money available to distribute in a different way. So, you know, that kind of shifted our perspective, I think, from us being like more money to, okay, then are there different ways of us providing services that would allow us to achieve our goals, and yet and do that by having a different way of being able to spend the money. So it's more flexible. We can think about service delivery in a different way. So we came up with a value statement that explains how and why school-based health centers are positioned to provide a range of services that address the triple aim, which is what the CCOs are focused on. I want to pause for a minute and say, if people have questions, feel free to interrupt me. So our actual statement, which isn't up on the slide, is school-based health centers are a cost-effective model offering accessible health services to children and adolescents in school. They address health disparities and social determinants of health, promote health literacy, and improve academic outcomes by keeping students in the classroom and ready to learn. So that's kind of the our core statement that we base everything else off of. And from that, we realized that we wanted to identify what actually our ideal services are. What does our ideal service model look like? Because if we're asking for funding to provide services in a different way, we don't want to ask for funding that's based on our model that we currently have, because that model has been developed based on the current payment system. So if we want to change the system, what is our ideal goal, end goal, for the way that our service delivery is going to look? And this is what we came up with. And we asked school-based health center providers to identify what their ideal service delivery model would look like, the types of services they would provide, who would provide the services, what kind of staffing there would be, and then what barriers are and possible solutions to the barriers are. And then we constantly refer back to this to ensure that any kind of APM that we're looking into would be linked back to this model and would help us move towards achieving this model. And here on this page, I'm not going to go through everything, but this is just so you have it. This is a definition of what all those rings are. So we included population health and preventive services at a community level, all of the school coordination and engagement services that we do and want to be doing more of, the youth-based population health and preventive services, like all of the student groups and health education classes, and then the integrated, the actual clinical services. And then you can see we have sort of what we think our ideal staffing would be there. Okay, so then the next question is, well, how would an APM actually fix the problems that we have? So to answer this question, we realized that we need to know and have an understanding of how school-based health center utilization fits into the larger context of healthcare utilization for school-based health center Medicaid clients. And let me see here. What's my next? Pardon me for a minute. So we also we took that question and it allowed us to identify ways to strengthen relationships between the school-based health center and the provider. And we wanted it to also provide insight into whether our current payment systems are appropriate for school-based health centers, or if there are other payment mechanisms that would be better. And we really needed to provide a better understanding of how school-based health centers are utilized within the larger Medicaid context, so that we could identify the gaps that they could fill and the services that they're really excelling at already. It was hard to have conversations without having this information. So we began a utilization analysis process, and as one of our lessons learned, sort of realized it would have been great if we would have done this in the beginning of the process. If anyone's going to move into an APM project of their own, we would highly recommend doing this at the beginning. But coming to that conclusion kind of helped us strengthen our own relationships with our work group. So, okay, so we started to dig into the data, and our partner HealthShare, they have all of the Medicaid data, and one of the challenges for them was specifically being able to see when patients went to the school-based health center, because as you probably know, there's a point of service code for school-based health centers. Although here in Oregon, we just started this year requiring school-based health centers to use a UB modifier code to identify when services were happening at the school-based health center versus, you know, the services showing up as just being the medical sponsor. So Multnomah County, which has, you know, I don't know, 30 clinics or something like that, but they couldn't see that it was a school-based health center that was doing the service. So our school-based health centers gave data to HealthShare on their visits, and HealthShare matched up that data with their own Medicaid data and did a comparison of youth that received services at the school-based health center versus youth that received some kind of service but not at the school-based health center. And a couple of our results are highlighted up here. One of the things they were able to produce for us were the maps that show where there's a high concentration of youth that have not received any health services. So they're signed up as members. They have Medicaid coverage, but they have not received any services within the last year, which is one of those gaps that we were talking about that possibly the school-based health center could be funded to address. We found out that school-based health centers provide services to youth of color at high rates, and you know, I'm talking about 2 systems right now in 2 different counties, and in the first system, specifically African American youth, in the second system, Hispanic youth, we're seeing at much higher rates, but even other populations of color we're seeing at higher rates in school-based health centers than in other types of providers. And then compared to their peers who do not engage with the school-based health center, the youth engaging with SBHCs basically are more complex patients. They have higher chronic disease rates, and they received more services generally, except for dental care, which a lot of the school-based health centers don't have available. And then there were some interesting cost observations that we made, which was that one of the systems basically had lower costs and the other had higher costs per member per month. And so that's something we're going to dig a little bit further into. But when we looked at the higher costs in the system, we also noted that in that system, patients were receiving greater numbers of visits. So it may simply be that they need more services because they are, you know, basically a sicker population, and so they go to the doctor more. And then really key to conversations with our CCOs, we looked at a couple of their metrics that they get incentivized payments for when they meet them. And one of the metrics they've had a very hard time meeting in Oregon is adolescent well visits. So we looked at the adolescent well visits, and you know, not surprisingly, patients that visited an SBHC had a significantly higher rate of having an adolescent well child visit than those who did not go to an SBHC. And also, in both systems, they had they were meeting the effective contraceptive metric at higher rates as well, even though not all of the school-based health centers provide contraception. So in one of the systems, I think all but one of the school-based health centers provide contraception, so we weren't surprised there. But in the other system, I think one of 3 SBHCs that we looked at provide contraception, and as a whole, they all still had much higher rates of effective contraception use than non-SBHC users. So our referral system must be pretty good, perhaps.
Maureen, it's John. Can I ask a question?
Yeah.
Tell me a little bit about costs. What's included in that calculation?
I don't have the details of that right now, but that's something I will be more prepared to answer at the conference when I'm presenting there.
Well, I guess to clarify, what I mean is cost to whom? Cost to Medicaid?
They were looking at actual, I believe they were looking at actual cost data. They were looking at the per member per month cost, and they were basing it off of you know, the standard Medicaid rates for the services that they sort of clumped into, you know, behavioral health, and then that they had clumped into the overall care. So the details,
yeah, this would presume then that all the visits to the school-based health centers were paid by somebody.
Can you repeat that? It was cutting a little bit.
All the visits to the school-based health centers are included within that cost data.
Yes, I believe so. Mm-hmm.
Okay.
And similarly, for the population that didn't receive care, all of the same, you know, all of the same services are clumped in. So we're comparing the two populations using the same services, which I do believe is all of them for the overall per member per month cost. She also split it out by behavioral health, but and that one was quite a bit more expensive if they're school-based health center providers, and I think that's because they actually have access to the behavioral health services. Although the data doesn't specifically show us that, because we didn't dive in that deeply. Other questions about this?
Yeah. What does the bottom line say? Receive adolescent.
Well child visits and effective contraception rates well above the 50% mark.
Thank you.
So we have that data. We're excited about that data. There's a lot of stuff in there that we can use when we're, making our case for school-based health centers being effective providers, and that we can also use in our advocacy too. So I'm really excited to have that data, but we also, every time we look at data, we want more. So we've kind of pushed our time with the CCO's research person to the limit, and now we're going to have the state program office, our state public health office, is going to sort of take over the analysis and look a little bit more deeply into it. So she is going to, let's see. Sorry, I looked at our sheets, and I'm going to have to explain some of that. She's going to look further into some of the data and try to delve deeper into the cost differences, and also some of the other information that we didn't see, like confidential services that weren't billed, to identify if we have more services that we can talk about that basically the Medicaid group hasn't been able to describe. So what we have the data. This whole time we've been working with our CCO, and then one of the very large payers in the state. They are both a part of HealthShare, and this is a little confusing, but they also own other parts of the state. So it's been really key to have them at our table, and they are called Care Oregon. And Care Oregon has agreed to look further into specific APM that they are beginning to pilot generally, and to think about how it might apply to school-based health centers. So I apologize, I don't have very good slides on this because it's just all very new. But we have talked to them to explore an enhanced model where they are providing enhanced payments for very specific codes that focus on behavioral health integration, and also things like telehealth, which a couple of our school-based health centers are exploring. So we wanted to also look into the school-based health center billing data to see how much our SBHC codes are already utilizing those enhanced payment codes, so we can see if their existing alternative payment model would benefit the school-based health centers without them changing anything, because it might just work. Because what's nice about it is that it's essentially still fee for service. It's just that there's a bump in payment for those specific services, which in theory could allow the school-based health centers to have just a little bit more revenue to play around with and think about how service delivery might change because of it. So we wanted to look into that. We wanted to look into the confidential services to see if we could continue to improve the adolescent well visit and the effective contraceptive measure in particular. And then look at which metrics that the SBHCs can help address, and look at what Care Oregon's priorities are, and compare those, and then begin talking about if there's the possibility of modifying the pilot to include codes that would be especially applicable to school-based health centers. And as I mentioned, we have our ideal service delivery model, so we want to make sure that we continue to refer to that and we don't go down a path of something that's doable but doesn't necessarily help us meet our end goal of making the service delivery look like what we want it to look like. So that's where we are with our model right now. We are going down that path. We have actually taken some steps to think about looking at specific school-based health centers, identifying how they're delivering services now, and then training them on this Care Oregon model, and taking another look in 6 months and then in a year to see if their revenue has increased and if their service delivery has changed. So this may not be, the silver bullet model. We don't know, but it's something that's really important for us to explore with a payer in particular, in order to continue to learn more, to know if it is the way to go or how we might learn from it to create something different. Because as I mentioned, the state is really pushing payers to move away from fee-for-service payments. And Care Oregon is using this pilot as a step to kind of slowly start to move providers in the direction of away from fee-for-service. So we hope to be there right along with them and be able to work together with them to have them create something that can apply to school-based health centers more directly. So our final question is, let me check my time. Our final question here was, who is responsible to pay for what? And this is just sort of at this point a philosophical question, because there are a lot of things that school-based health centers do. Some of them are public health. Some of them are clinical health. Some of them are mental health. Some of them are school related and related to school outcomes. And so, there's kind of a philosophical conversation as we're working with the CCOs about what they are responsible for versus other people. So that's just something to keep in mind. Okay, so that's what I have. Do people have any more questions?
Maureen, this is Stacy. I have a quick question about, was there any particular reason that you decided to work with HealthShare originally, why you chose them, or was it geographical?
It was because actually Multnomah County in the Portland metro area was the original applicant for the grant. And then they pulled us in as consultants and made it a tri-county effort. So they happen to be the Medicaid provider in the tri-county area is all.
Maureen, it's John. Could you go back to the slide around the description of the different payment models? There was one that was capitation, close to the beginning of the presentation.
Yeah. Let's see. Yep.
There we go. How many of the school-based health centers or what percentage of school-based health centers are currently seeing any of these kinds of in their practice through this work?
Okay, you cut out, but let me see if I can guess what you said. Were you asking how many of them participate in other types of these other types of APMs?
Right, or any of them getting primary care capitation or pay for performance incentive? What's the breakdown across these models?
Yeah, so what's really interesting, I don't know statewide at this point, but what has been interesting about this project is we have learned that across the three counties we've been looking, they're actually, the medical sponsor is participating in a number of different APMs, and the SBHC doesn't even know about it. So you know, how can they maximize their revenue if they don't even know that they're already participating? So that's been something really interesting to find. Like in Multnomah County, they are participating in a capitated rate APM that federally qualified health centers are doing. They didn't know that right away. They are participating in a pay-for-performance APM, which they didn't know about either, and they were not included in the process of selecting which metrics they wanted to try to address, the incentive metrics. And now they are participating in the Care Oregon enhanced payment, but they just found that out as we looked into it literally this week. And so they have no idea how to, you know, right now, how to maximize that APM that exists, which is why we're also going to work with Care Oregon to get them trained on the APM and how to do the billing, and then also be thinking about how change service delivery based on it. So I think this is probably a rampant issue across the state because all the CCOs are trying some kind of alternative payment method. And so I think part of our project needs to be to figure out how to help that school-based health centers, you know, work with the medical sponsors to understand how they can benefit and hopefully to make sure that they are benefiting and that additional revenue doesn't stay at the high level all of the time, that some of it, you know, floats down to the school-based health centers so they have more revenue from it.
Thank you.
Are there any other questions? And I'm happy to answer email, and I'm also going to be presenting at the national conference, and I think hopefully we'll be a little further along because we're kind of moving faster with Care Oregon now that we've gotten it going. So we hopefully will have a little bit more information even by June.
Maureen, can I ask you just a quick question? So yeah. if something like this was to be, you know, piloted in another state, what would you say that has been, you know, it seems like having a wealth of different partners who can provide data and, you know, all the CCOs involved, et cetera. What other components would you feel like are replicable to other states?
Well, I think some variation of the ideal service delivery model is pretty important when you're talking to payers, to be very, very clear about what it is that you're asking for, like what sort of your long-term vision is, and then as you're taking these short-term steps, what you're asking for. And I think that that's replicable. Like I think of it's kind of similar to what Connecticut has been doing with their patient-centered primary care initiative, I think. So I think that piece is, and then yeah, I would say the relationship building and the data gathering are two components that are critical and are replicable.
Great. Thank you. Anyone else?
Yeah, I have a kind of like a, maybe it's too micro of a question, but when you spoke about confidential services not being billed for, this is Molly, by the way, hi. Was that really around sites maximizing their billing around confidential services, or have you had things that have not been traditionally been able to be billed for under that category?
It's about maximizing the billing, but also about exploring with payers what that might mean to their, what that possibly means now, or what that might mean if they were expanded to their sort of their bottom line in terms of their metrics or outcomes they're trying to meet. And specifically, Multnomah County has a deal with Kaiser Permanente where Kaiser will provide them with essentially a case rate for their patients, which of course is out of network, so they don't do it with anybody else. And then that case rate is essentially for Multnomah County to provide reproductive health services to kids who won't go to their Kaiser doctors. And then Multnomah County will make sure, they have an agreement to make sure to provide information on the visit and then try to route the patient back to Kaiser. So that's an example of how they took something that they were doing really well and took it to the payer and presented it to them and said, we're not getting reimbursed for any of these services. And then we're able to, it actually took years, but after years they were able to negotiate an agreement with them to get some payment where there wasn't any before.
That's amazing.
Yeah.
That's a really exciting partnership.
So I'm happy to answer questions via email, or you can give me a call or catch me at the conference too.
Thank you so much, Maureen. We really appreciate you taking the time to put together this presentation and to tell us about what's happening in the state of Oregon.
Happy to share.
Thanks, everyone.
Thank you. Thanks, Maureen.
Welcome.
Thank you.